Howdy learners, welcome to eLearn 16.2, The Worthy Bride to the Statins, Part 2. This is a schema of how PCSK9 inhibitors work. PCSK9 would bind with the LDL receptor, thereby causing the whole complex to be destroyed by the hepatocytes, rather than allowing the LDL receptor to be recycled onto the surface of the hepatocytes. This leads to raised LDL levels in the body of those with PCSK9. Evolutimab and alirocumab are PCSK9 inhibitors, and as it suggests, would bind to PCSK9 so that it's not able to bind with the LDL receptor. This way, the LDL receptor is freed up to continue binding with the LDL to clear it out from the hepatocytes. And as a result, because the complex is not what causes the destruction, the LDL receptor is now being able to recycle to the surface of the hepatocyte so that it can continue to do its job to lower the LDL levels in our body. So this is like a kamikaze effect where PCSK9 binds to the LDL receptor and the whole thing gets destroyed. Proprotein convertase subtilisin cursin type 9 inhibitors is the expanded name for the PCSK9 inhibitors. The hallmarks of these classes of agents is very interesting, and they're actually human monoclonal antibodies. How you know they are human monoclonal antibodies is by the nomenclature ending with chumab at the back. They are injectables and they are used every other week or monthly. In Singapore, what is labeled for use and registered here is the every other week preparation of evolutimab as well as alirocumab. The clinical effects of PCSK9 inhibitors, of course, was to lower the LDL, and it's also got an impact with the lowering of triglycerides as well as Lp(a). It's been studied and labeled for LDL reduction and also a reduction in major adverse cardiovascular events. The clinical impact of reduction of triglycerides need to be studied further in hypertriglyceridemia patients. Both have been studied in atherosclerotic cardiovascular disease or ASCVD, and they managed to show a combined endpoint reduction of cardiovascular heart disease death, non-fatal MI, ischemic stroke, or unstable angina that requires hospitalization. But they were not able to demonstrate cardiovascular mortality benefit. What does that mean, you might ask? Well, it means that the studies used a combined endpoint that have got all these other outcomes. And when you just look at the CV mortality benefit alone, there was no significant reduction. This could be likely because there is not enough power to show one endpoint, but when you collectively put all endpoints together, you manage to show a significant reduction because collectively there are more events. Alirocumab, on the other hand, demonstrated reduced all-cause mortality, and this might be thought that is due to chance. Due to exorbitant costs, it's unlikely that it will be cost-effective for all patients, and therefore we use them only in the very high-risk ASCVD patients as a backup and next-line therapy after the statins and ezetimibe. For a caution, be very careful for people with possible hypersensitivity reactions because there could be cross-reactivity. In the patient population of pregnancy and lactation, there's actually not much known information. Where the adverse drug reactions are concerned, it is an injection and therefore it's expected there will be some sort of itching at the sites and also some flu-like symptoms. There were some early concerns of neurocognitive function because of the extreme lowering of LDL to very low levels and also increased DM risks. But later on, they were shown not to be a significant issue. This plot over here could further illustrate what we were talking about earlier in the earlier slide. Ben et al. Published this in JACC 2019. What they were trying to show with the y-axis and the x-axis was the degree of risk ratio or cardiac mortality reduction with the reduction of LDL on the x-axis. You can see that the lines in general are pointing downwards, which means that the level of cardiovascular mortality seems to be correlated with the degree of LDL lowering from baseline. The curves in blue are from the statin studies, and the curves in red are from the PCSK9 studies. Do note that the risk of major adverse cardiovascular events is directly proportionate with the LDL reduction from all the PCSK9 studies, but recall that they did not manage to show a reduction in cardiovascular mortality per se. Therefore, the conclusion was that while it reduces MACE, it is still cost-effective for those with very, very high risk. But because they were not able to show a reduction in cardiovascular mortality, the benefit in the lower cardiovascular risk patient population is not very well defined. Next, we also talked about how alirocumab reduced all-cause mortality, which may potentially be due to chance. On this other curve, the same group plotted the all-cause mortality on a separate curve. You can see that the gradient seems to be slightly less than that seen for the cardiovascular mortality. That being said, again, the all-cause mortality claims is very hard to substantiate because what you're trying to do with LDL reduction is really trying to reduce cardiovascular mortality. So the controversy was arisen that how is it that all-cause mortality could be reduced, but then it's not attributable to cardiovascular mortality? So I leave you with that particular question. One of the early concerns with use of antibody treatments over time was the production of autoantibodies, and this was what led to the discontinuation of botrasizumab with the attenuation of its LDL lowering effects over time and also larger injection site reactions. Evolocumab and alirocumab are fully human antibodies and therefore they do not seem to suffer the same fate. How can you tell where these monoclonal antibodies are produced from? Here's a geeky fact. Look at the part just before the map. And with botrasizumab, we can see that these monoclonal antibodies are humanized, whereas evolocumab and alirocumab are actually purely human because they just have a U before the map. Here's a geeky fact for you. So here is another piece of proof that from the Osler study, you could see that the alirocumab LDL lowering propensity stays constant throughout the 5 years. Also, they didn't find any neutralizing antibodies that's detected over this period of time. So here are what the pens evolocumab and alirocumab look like. There are links at the bottom of the page for you to go to in YouTube to look at patient instructional video. And those are going to be a lot more effective than me narrating through the steps. So to summarize, the medications need to be stored in the refrigerator and to be brought up to room temperature only about 30 to 40 minutes to warm up before use. They may be kept at room temperature, which is really 25 degrees Celsius. So in Singapore, it really is a bit too warm for up to 30 days. And the instruction is not to put it back when it's already been taken out to be warmed up. Here's an algorithm for the pharmacological lowering of low density lipoprotein cholesterol. And essentially, I just want to bring your attention to this particular box over here. The numbers are a bit tiny, but it shows you collectively how much more the PCSK9 inhibitor actually adds on to high-intensity statin therapies. And the impressive lowering of LDL can be up to even 85%. So the following chart over here actually guides you through a decision-making algorithm. And in live lectures, we're talking about CV risk assessments, similar to the hypertension one, and whether there's indication for drug therapy following the CV risk assessment. And essentially, if yes, the answer is you need treatment, we would then go and see how much of the statin is required. Now, if the high potency statin is required at the highest dose that's recommended, then we try and give the statin at the highest dose and then repeat LDL levels to see whether it's been achieved. And if it was, we'll be following up annually or more frequently as indicated. But if it's not, we'll then add ezetimibe over here in this pathway and then repeat again LDL. And then to see whether it's been reached or not in terms of goals. But if it's not, then that's when we add PCSK9 inhibitor and consider adding PCSK9 inhibitor for primary prevention only in very high risk, but without familial hypercholesterolemia. Essentially, the people who are considered very high risk are the people with secondary prevention, meaning those who have already developed an ASCVD, potentially people with also concomitant diabetes on top of the ASCVD, and primary prevention for patients with familial hypercholesterolemia FH or another major risk factors. They are considered very high risk patients, which would warrant the use of PCSK9 inhibitors. I find the schema a bit easier to understand, and I would like everyone to take note of this, particularly because this is an ASCVD type of a direct patient population. Now, ASCVD with specifics to the cardio side of things, we're talking about stable angina, which we'll be covering a little bit more with Dr. Wee Xue Ting, as well as acute coronary syndromes, which comprise of the ST elevation myocardial infarction, non-ST elevation MI, as well as unstable angina. So what happens if you have a post-acute coronary syndrome patient or coronary artery disease with hypercholesterolemia? You would then think about the target of less than 1.8 millimoles per liter. In American references, you see it in milligrams per deciliter. And to interconvert, you would divide that by 39. So the starting point is always a statin therapy. And when you are not able to achieve less than 1.8, that's when you add the ezetimibe therapy on the blue box on the right hand side. And if you're then happy and achieved 1.8, then you're happy. But if it's not yet less than 1.8, that's when you add the PCSK9 inhibitors. If you basically look at the European guidelines, they have pushed for a further limit to lower LDL to even 1.4 millimoles per liter. I can't say that I stand for that because I think it's critically difficult to achieve less than 1.4 even in local setting, and PCSK9 inhibitors are currently very out of reach for our patients. It costs a patient for at least $500 to $600 a month if they were to use an injection every 2 weeks in the restructured hospital setting. In the private setting, it could be as much as 30 to 50% more depending on the markups that are used in the private clinics. Here's just to remind everyone there are other types of ASCVD, and that includes the cerebrovascular accident or CVA, the transient ischemic attack patient population, the carotid artery disease patient population, as well as the peripheral artery disease patient population. Here's a monitoring scheme for people on lipid-lowering agents. Let's talk through them one by one. And I would like you to remember about some of the minimum intervals. You don't need to memorize every single thing, but some of the intervals in red in this slide over here. So for the lipid levels, I'm talking about the full lipid panel, which is LDL, triglycerides, as well as HDL. It should be done at least 4 to up to 12 weeks after starting treatment, and adjustments each time until the goal is reached. And then when the goal has been attained, you don't really need to repeat it so frequently anymore, just maybe once a year. Now, different recommendations may differ because of the way that they practice. Particularly if you ask renal medicine, they may just say fire and forget, meaning that you start the statin and then you don't ever need to look at the lipids ever again because they don't quite believe in titration of the lipids. Now, the labs no longer require fasting overnight. In the past, the LDL levels are derived from triglyceride levels as well as HDL levels in the equation called the Fred-Wald equation. Most labs today measure the LDL levels directly, and so there's no need to worry too much about fasting overnight anymore. Now, high triglyceride levels should always warrant consideration to treat and recovering triglycerides in a different series of e-learn. For the ALT and AST levels, it's important to think about repeating it in the same time interval of about 8 weeks to 12 weeks after starting and after dose increase. And this follows the same schema that we saw in the statin series of e-learn. Now, remember that routine ALT repeating should not be recommended if on statin. And if someone is already stable, there's really no need to serially repeat the ALT or the AST. Now, if they are on fibrates as well, then you need to consider routine repeats because both of them are also liver toxic agents and therefore could cause problems in time, particularly if the patients have other risk factors, like if they use alcohol quite a bit. Now, the schema is on the right-hand side and similar to what we talked about with respect to the upper limit normal. Basically, the schema will also follow. I don't need you to memorize it. Just reason out what needs to be done according to the time frame because, again, as I mentioned earlier, the policies may change, the protocols may change from location to location. For the CK levels, as we've discussed earlier, routine monitoring is not necessary, and only if patient complains of myalgia that you might want to offer the measuring of CK. Now, remember to refer to the algorithm for decision making because it's pretty complex. However, the most important thing is for you to be alert regarding myopathies. And if there's CK elevation in at-risk patients, particularly if they're very old, they have potentially interfering therapy like drug-drug interactions, multiple medications, liver or renal disease, and even athletes, you might want to be alert for the risk of rhabdomyolysis, as we've discussed earlier, looking for red to brown coloration of urine. Again, you might want to discuss this with a patient who is on a statin. With respect to HbA1c, there's no real need to, again, serially check it, but regular checks for high-risk patients at risk of diabetes or maybe high-dose statins could be warranted. Now, if the glucose is raised, then you might want to consider treatment. For people, particularly if they're elderly, they could look like they've got metabolic syndrome, obesity, or other signs of insulin resistance.